next I'd like to welcome Jeff Roizen from Children's Hospital of Philadelphia, who will talk to us about endocrine management across a lifespan. And also just a quick announcement from our video team. Just don't be worried, all the videos from today and from yesterday within the next couple of weeks will make it onto the ALD Connect website. So it'll be there for you to access.
Thank you. Thank you. Thanks so much. It's really a great honor to be here in front of this group. I'm going to speak briefly about sort of long-term management of endocrine complications, but I suspect that many of you have significantly more experience than I do. So I'm excited to answer questions at the end. I'm from the Children's Hospital of Philadelphia and the University of Pennsylvania. I have no conflicts of interest. If you have a conflict you wish to pose to me, I'm interested to hear about it, but as of now, I don't have any. And I will not be talking about any unapproved use of medications, at least before the questions. If you have a question about an unapproved use, I'll answer it to the best of my knowledge. So briefly, I'm going to talk about sort of endocrine care and adrenoleukodystrophies, and then I'm going to talk about other considerations. And by that, I sort of mean like practical considerations for college-age boys. So the big picture challenges are basically that there's adrenal insufficiency, which is decreased adrenaline, decreased glucocorticoids. There's some evidence that in many kids there's mineralocorticoid insufficiency or decreased aldosterone, and then there's hypogonadism in a significant portion of kids with adrenoleukodystrophy. In terms of focus questions, or questions that I get a ton, I get a lot of questions about stress dosing, when, why, and how, and then how to achieve, to the extent possible, healthy longevity. And so those are two things I'm going to focus a lot on. In terms of the signs of adrenal insufficiency, so we test about annually, or sometimes depending on the child every 6 months. But what often happens is someone gets sick and then they come in and they've had a crisis. So it's worthwhile to know the signs and symptoms so that if you feel like you're experiencing these, or someone you love is experiencing sort of poor growth or weight loss, that you can maybe say, hey, maybe we should test before that 6-month time point. Because it's terrible to sort of have a lingering illness where you're not feeling great and you can't sort of put your finger on what's going on, and then suddenly you get a steroid and you feel much better. And it may be that not getting that sort of early may worsen the course of the disease. We don't have great evidence either way, but now that we're doing sort of newborn screening, it may be that we'll find that by treating this early, we can sort of slow progression of the disease, but there's not great evidence as to now either way. But the things to look for are poor growth, weight loss, dehydration. If you get a viral illness and you're sort of just not getting better, you can't sort of quite feel normal, that's a reason to test. If it's gone on for a long time, you might get decreased pubic hair, low blood pressure, low glucose. Those are signs of a crisis. If you're sort of getting lightheaded when you stand up, that's a really concerning sign. And it's very uncommon in sort of a teenage boy to have that in the absence of something like this. And then altered mental status. The symptoms are things like weakness and fatigue, or decreased appetite, and sometimes you just feel nausea or just like not quite so hungry. They're GI symptoms. If you're in adrenal crisis, that can be things like vomiting, but it can just be sort of persistent nausea. And then salt craving and increased peeing. I talked about postural dizziness or syncope. And then some people, and this isn't what I've seen a lot, but some people have like muscle pains, and again, sort of vague symptoms. And that's the most common thing that people present with, is sort of a vague malaise. And maybe it's muscle pains or stomach ache or just not quite feeling right. And then in crisis, you can have confusion or dementia or even sort of aggressiveness. So the thing about stress dosing, and this is, I'm sort of bringing my experience with other kids who have adrenal insufficiency in here. So we talk about stress dosing. You should do it when you have a fever. You should do it when you have an obvious illness. I have a number of children with other diseases who they do it when they're doing something sort of not necessarily stressful to your body, but either psychiatrically stressful or physiologically stressful. And what I mean by that is I have a group of twin brothers, one of whom has adrenal insufficiency, the other of whom doesn't. And the twin who has it, when he plays hockey, he needs to get a stress dose. Otherwise, the full day after playing hockey, he's totally dead. And so it's worth considering, if you're someone who does do exercise, that you might need, if not a full stress dose, maybe a partial stress dose to get through that and feel sort of normal the next day. Not everyone has this, but some people do, and it's worth considering. I think a lot of endocrinologists, certainly in my institution, think of replacing adrenal function as like a one-size-fits-all approach, but there's really a range of doses that work for a population, and you may find that your dose is either on the low end or the high end. And I have some kids who are really very much on the high end, but who do very well. They don't have any of the problems of excess. And then I have other kids who are very much on the low end, and they don't have any of the problems of deficiency on the low dose. So that's sort of the when and why. So if you're really sick, you need, obviously, the injectable if you can't eat, if you're vomiting. But if you're sort of just a little sick, I would try the oral stress doses. And then when I talk about how, I guess really what I mean is, do you need the oral dose or the injectable? And the decision sort of point for me is whether you can take oral. Some people, when they take the oral, it makes you feel nauseous and you throw that up, and that's, again, a sign that you need the injectable. So a lot of text on this page, I apologize. But so a problem that I've seen come up a number of times is that the family knows what to do and the individual who has the disease knows what to do, but they're doing something that's out of the ordinary. And out of the ordinary can just be going on a class trip or going for an overnight at one of their friends, and then they get sick and they're not able to sort of totally communicate well what they need. And so wherever you go, you should always, have written instructions that you can just hand to someone, so that if you're not sort of aware or you're in trouble, you can hand it to someone. I would also say, always have either the bracelet or the necklace. And this seems silly, and kids will often say to me, well, I'm super careful, I'm super alert. When I feel different, I'll be able to tell someone. But what happens is, and this is true in all walks of life, something unexpected happens. You're in a car accident, God forbid. And the only time someone with diabetes dies in America, if you are well controlled, is if you're in a car accident and then you go to the ER and you're like in shock and they don't know that you have diabetes and they don't appropriately treat you. And the same thing can happen to someone with ALD. You get in a car accident and you have a adrenal crisis and you go to the emergency room and the people there don't know what you have because you don't have the bracelet on. And so instead of this being just a terrible car accident and you doing fine, it becomes a cause of real disability or death, God forbid. So I would urge you to wear the bracelet. And then there's a template for the instructions. I don't know if there's a laser here, but I'll bet there is. There's a template for the instructions at this website, the Pediatric Endo Society. And you can download that and just fill them in, and then you'll just always have it. It seems silly, but it's no less silly than like carrying around your ID. Mineralocorticoid deficiency. So this is thought to be quite rare in kids with ALD, but I've seen a number of children who have it. They seem to be doing fine. They seem to have suppressed ACTHs in terms of their glucocorticoid replacement, but they have salt craving, or they feel like when they stand up, they feel lightheaded. And when we test, we look for what's called a CMP to look for sodium and a renin, but the things that, the sort of symptoms that patients report are salt craving, fatigue, and sometimes just feeling fuzzy. And then lightheadedness when you stand up, or your heart beating super fast. So I would say about a third of the kids I see with ALD are on mineralocorticoid replacement. Sometimes, for one of them, the only symptom that he had was just not feeling quite right, but his ACTH was appropriately suppressed, so he was really, I think, getting appropriate glucocorticoids, and he just needed a little bump of the mineralocorticoids. And then hypogonadism, and there's sort of a laundry list of symptoms that go with this, but there's sort of all the things that Ben sort of spoke about that our society sort of defines as being manly. So you have reduced sexual desire, you have reduced sort of spontaneous erections when you're asleep, decreased body hair, decreased muscle mass. And all of these things, so again, some of my colleagues I feel like are less aggressive to replace testosterone, but it really is something that can cause depression, that can cause feeling bad about yourself, and that can lose muscle mass. And so if your goal is sort of long-term functionality, your goal is to be able to walk for a very long time, the more muscle you start with, the more muscle you maintain, the easier it is to do that. And so this is something that I don't know if I would say I'm aggressive with, but I'm appropriate with replacing. And I would say that if you feel like your endocrinologist or your other physician who's caring for you is not inquiring about this, trying to find out if this is possibly deficient, push for them to look for it, because it's something that's maybe awkward to talk about and that they may not want to bring up. But if you don't bring it up, you may just miss out. Finally, so there are case reports of a number of different types of endocrine deficiencies in ALD. And what I would say is that in general, if you have ALD, you're no less likely to have any of these other endocrine problems, but you might be less likely to have people look for them, particularly hypothyroidism. So hypothyroidism looks very much like having adrenal insufficiency, or very much like hypogonadism. And so these are things that I would sort of have people look for annually, but that generally, I don't think they're any more likely to happen in individuals with ALD. They're just not any less likely, and I'd be ashamed to miss them because the symptoms look very much like other symptoms of ALD. Finally, other considerations. So for teenagers and adults, our knowledge about the pathophysiology of this disease is, still in progress. And, as my father liked to say, you only get so many neurons. And so it's sort of obvious with the data on head trauma, maybe football is not the best sport maybe for anyone, if you ask me, but particularly if you have a susceptibility or some risk that is dramatically increased by it, you really should avoid, sports where you're going to be bumping your head either deliberately or accidentally. So that can be hockey, football, basketball if you're, playing in my neighborhood. But other things that cause neural death, like alcohol or other substances, and by that I mean, LSD, pot, whatever, these are things you want to do very judiciously, because what you need to think about is, are you trading away 5 years of function in the distant future for one night of fun, so to speak? But the flip side to that is also true. It's really tough, particularly when your son goes to college, to say, you're going to go live. You shouldn't just live every day worrying. That sucks to live every day worrying. So I'm not saying, don't ever have a single drink, but I'm saying just be judicious. And that's, I think, the entirety of my talk. Get appropriate sleep. So this seems silly, but in America, much more so than in Europe, we live in a culture where it's really sexy to be a workaholic. But in Europe, they get just as much work done as we do, and they don't push themselves to sleep 4 hours a night. And the effects of sleep on neural function and on brain function are really fairly dramatic. So it seems silly to me, but when you go off to college or even after college or when you're in your competitive job, make sure you're getting enough sleep, and in addition to avoiding bumping your head. Thank you, and these are people who sponsor me.
Yeah. Thank you so much for coming.
My pleasure. Thank you for having me.
Yeah, there's a bunch of questions. If I can just, before I pass on, you said avoid things that cause oxidative stress, like what?
Like alcohol, maybe. I mean, it's not.
Oh, okay.
Or things that specifically cause oxidative brain stress, so bumping your head, getting too little sleep. You might think, sort of think of them as we don't totally understand what causes seizures, but the things that lower your seizure threshold probably also lower your threshold to having complications.
Hello. Outside of the sort of 3 traditional medications which are used for this, which are hydrocortisone, fludrocortisone, and methylprednisone. Mm-hmm. Those are sort of the 3 standards. Are there any other medications, supplements, anything else that you know of or would recommend as a potential benefit for endocrinological issues?
So there's also testosterone for specific people who need it, and then the glucocorticoid family has different half-lives, and then these half-lives are described in a population, but you may find someone. So I have, and this seems strange, but I have 2 fast metabolizers of hydrocortisone, and if they take the pill in the morning, by noon it's way gone. So I have them on prednisone, but it's a different glucocorticoid, but it's worth considering a longer acting. But the goal is, we think, to mimic the natural sort of peak and trough.
Hello. Yeah, I think methylprednisone is longer acting.
Yeah,
I've
absolutely.
used both. I've used hydrocortisone and methyl. Methylprednisone works better on me, and I know it does pretty definitively.
And I think that may absolutely be true for you. And I have a patient who he swears by.
But you mentioned testosterone.
For people
what
that
do you mean by that? Do you mean testosterone replacement therapies? Talk more about testosterone.
I mean testosterone replacement therapies. So for people who are who have low testosterone or evidence that they're hypogonadal, either because they have elevated gonadotropins or very low testosterone, this is something that can maintain or improve muscle mass, can for sure improve sort of mood, and can improve a bunch of other things. So it improves your glucose toxicity. It improves a bunch of different things. But in general, it seems to have a positive effect in people who seem to need it.
I have a question about ACTH monitoring, and would like to get your opinion on what role, if any, does ACTH monitoring have as far as appropriate treatment for Addison's disease? Or is it more used in the diagnostic setting?
So I think different people have different styles, and so it's I think obviously useful in diagnosis. For me, the sort of decision points are like, does someone feel like they're running out of energy in the afternoon, and then we see if maybe we can go up on their glucocorticoid, and then we check the ACTH after we go up, and if it's super suppressed, we might say maybe it's unrelated to that. But if it's sort of not super suppressed, so I actually aim for the ACTH to be detectable but not high. But really, it's how people feel is what helps me make at least the initial decisions. A problem with that is that most humans, if you give them too much glucocorticoid, feel great initially and then terrible later. And so when I go up sort of by small increments. But
so if I can ask just a follow-up question. So in my conversations with some mothers who have ALD boys and who are already symptomatic in terms of Addison's disease and adrenal insufficiency, they're often too young to maybe explain how they feel. And I was curious about how ACTH factors into what an endocrinologist would do to treat, say, fatigue, because clearly the boys are expressing, that they're tired all the time, but that's hard to quantify.
Right, I think it's not always quantifiable. I mean, I would say that the goal is to not have it be, if it's super high, I think you're almost certainly under replacing, and if it's like undetectable, you're almost certainly over replacing. And so part of it is if we change the dose and the growth is doing well, we're probably not too far low or too far high. But usually the fatigue is associated with like a growth plateau in the younger kids, but that it takes 3 to 6 months for you to see that. But that's been my experience.
Hi. My son is 20. He's got ALD. He's now 11 years post-transplant and sadly not in college. We did introduce medical marijuana 2 years ago, and I haven't seen any bad side effects. It's been very positive in a lot of ways. You say to avoid such things. Is there anything I should be looking for?
So I guess it may depend on how you're administering it. I guess my big bias would be against taking it in via smoke, but I would say that there's not a lot of data that it necessarily causes that the compound itself causes oxidative stress, just that smoking causes oxidative stress. So particularly if you're seeing benefit giving it through another method, I would say that that's great. It'd be nice if we had a study that showed benefit for more people, and then there'd be less of a stigma associated with it.
I don't know if you were here before when the question was about the pump. So just so you live in this world, so have you seen the pump for cortisol?
I haven't seen it used. A challenge with that is that so for research we can get cortisol that's fairly standard in terms of its concentration, but if you're putting cortisol in a liquid for a human in your body, it usually has to be compounded. And some pharmacists are really conscientious, but others, and particularly with cortisol, it's been a source of like a number of chronic infections. And so it's something that I would be careful about. I could imagine that if there's a particular time of day when you're low, when you feel terrible, and it happens to be right before you're going to bed, and so you want to have like a peak that just drops sort of precipitously with bedtime, that you might benefit from a pump, but it's not something that I've personally ever used.
Hi, I was just wondering, is your standard of care, I'm a mother of a newborn screen baby, is your standard of care to start at 6 months? Because, for instance, so recently they just came out with this article the journal article, it was recently just in October. I think it was like October 4th. For instance, my son was picked up as having adrenal impairment, at 4 months. So, thankfully we were plugged in, very, very early and followed. And then, he had to start stress dosing as early as 4 months. And then we had to start daily replacement even at 10 months. So I think with these newborn screen children, we're going to be learning more and more, when this starts. So, are you,
That's a great question. I think, as you're saying, with the newborn screen, we're going to learn not an infinite amount more, but a huge amount more about when things occur. And the assumption was always that adrenal insufficiency was a late effect. But in many people, it seems to be a very early effect. At CHAP, we screen at their first visit, which usually is in the first sort of 3 months of life, and then at 6 months, and then at 12 months, and then annually. But we're sort of aggressive about asking how kids feel. And then our neurologists are really great partners with me. And so when a kid comes in sick, if there's anything a little bit concerning, they get a cortisol and an ACTH. And so we've caught a number of kids between the 3-month, 6-month time point who came in with what seems like a virus, but really a terrible virus. And so they were really adrenally insufficient and needed stress doses very early, as you're saying.
okay. Because clearly they're following growth as well. But we're on a standard protocol of following every 3 to 4 months. And then between the pediatrician and the endocrinologist, watching growth. And obviously, if you're having illnesses and things like that, stress dosing appropriately. Certainly, before MRIs. Because both my children have adrenal insufficiency. And certainly everybody's going to be, it's individual when you are going to develop adrenal insufficiency. So it's not a standard, but at least you'll be caught somewhere in these windows.
Right. Hopefully, with a short window of being insufficient.
Because I just know, with this journal article, they were saying 3 to 4 months up to age 2, and then after age 2, every 6 months, just as a sort of best guidelines, because they don't really have enough data yet. But they are seeing more and more early
younger and younger.
incidents. Yeah.
And CHAP, are you doing it before MRI?
Yes. Yeah, we're doing it at diagnosis. So we're usually I can't remember when they decided to get the first MRI.
Are you giving stress dose steroids? So this might be a stupid question, but one thought that's bothered me is if we've started to give stress dose steroids before sedation for the MRI, and one thought I've had is how fast does that get to the blood-brain barrier, and could we hide contrast enhancement? And so I just don't know, is it actually necessary for the stress of conscious sedation to give a higher dose of steroids or not?
I would say it's an area of controversy. We try and test before the first MRI so that we have an idea about whether there's a need for it. If there were someone coming in and having an MRI, we think that generally, and this is again a style thing, that generally kids don't need stress doses but probably need physiologic doses. And so we would give physiologic doses whether or not they had been diagnosed as insufficient if they were getting an MRI before we tested. But it's controversial, so some people will say they absolutely need stress doses. But in adults, for instance, they don't give stress dose even for full anesthesia currently, because it seems like what the support is needed is just physiologic rather than stress. Thanks very much.